Hey, good evening, everyone. Aaron Hackett here with A-Witty PT, Dark Secrets to Skilled Care over on Facebook. Sorry, I haven't been as active recently, just having fun with the summer, trying to spend time with kids, all that kind of stuff. But I got a really great question, and I want to get to it quick because part of my response takes quite a bit of time to read, and I only have so much time that I can record this. So um, just, I promise, get all the way through it. I think it will be helpful to everyone. In my group on Facebook, there's a question about lengthy, wordy, jargony documentation. So documentation dissertations, that's what I like to call that. Also known as the physio filibuster. Okay, we all know what a filibuster is. It's, spewing out information to obstruct and waste time, basically. If you don't know a lot about it, just go watch CNN. Anyways, there was a question in my group about this using is there a benefit to having super long assessments or having a lot of information in there? Basically, my response is that in most cases, I don't think so. Unless that information is super useful, there are some very complex cases in physical therapy, but more often than not, you want to try and keep it as simple as possible. That functional information about the patient and their progress, and leave it at that. I would even say tables, bullets, whatever you can do to make it simple. Almost think of it like a resume of what happened that day. Would you write an 18-page resume? I doubt it. Okay, so think about it that way. We're going to get into this real quick. I have two examples. I want to try and read them as quickly as I can. Just to give you an example of really how long some of these can be, and then my recommendation. All right, big breath, here we go. Jane Doe has been seen 4 times. She has gone from being fairly overwhelmed by all the changes she has had to face after being diagnosed with MS to being much more informed, with better support from her husband and the rest of her family. She has undergone driving assessment and will continue to drive, but may limit herself to daytime driving. She will try baclofen to see if this helps with the pain in her right thigh. She had a question about drug interaction with gabapentin. She has returned to working out at a gym and feels good about that. Additionally, she is attending classes and doing individual sessions with Captain America, athletic trainer, with specific interest in working with people with MS. She is attending an MS support group. Today she attends with her husband, John, who had good observations and suggestions. She had questions about when to wear her brace, whether she could continue to wear it at all times. We discussed that her dyskinesis is not something that will improve with strength training, and that it is important that she wear her brace at all times. Similarly, the sticks enable her to swing her left arm appropriately. Walking today looked much easier in terms of not having to focus on the sequence of the steps and sticks. Score on the ABC increased 70%. John agreed that her scores were reasonable. Score on evaluation is 42%. We discussed that distractions as well as lots of turns in succession will affect her stability, as well as fatigue. This will dictate when she should be using her walking sticks and when she can do without. On her property where she is familiar, for example, she likely would not need to use her sticks. In the community where she has less control, she should be using them. She was encouraged to slowly increase her exercise load, or at least vary her exercises. That, though it is not bad when she does something, she should learn from that to dosage her exercise more appropriately the next time. I would like to see Jane on a less frequent basis while she continues to have questions related to exercise and mobility as it pertains to her MS. Whew! Okay. Now here's my recommendation, just a real quick one, without really having seen the patient. Jane Doe has been seen 4 times. She is less overwhelmed and family is getting better and assisting. She is able to daytime drive. She will try baclofen for pain. She has returned to working out at a gym with Captain America, athletic trainer, with specific interest in working with people with MS. Today she attends with her husband, who had good observations and suggestions. Questions about brace, walking sticks, and dyskinesis addressed. Decreased focus required with walking. ABC increased from 70% to 42% at eval. Education and training regarding distractions, environment changes, adaptation with an assistive device. Home exercise program, dosage and intensity modified. Educated on slow progress. Recommending decreased frequency in PT to allow more time for progress between visits. So it may not seem like it, but I cut it down by about 75% based on how many lines of text counted there are in both of those versions. The first version had good information, but it had tons of fluff. stuff that just, it doesn't need to be in that assessment. The first one I read, that was a daily note. It wasn't even an evaluation or a reevaluation. Can you imagine writing that every day for every patient that you see? Crazy. Okay, second example, really quick. 45-year-old female who presented to physical therapy on 6/20 with primary complaints of low back pain that began in May after doing some cleaning, moving things around her shop. She currently presents at reevaluation with significant improvements in reduced impairments in lumbar range of motion, limited and painful, improved piriformis, iliopsoas, quadriceps flexibility from moderate to mild, continues to present with reduced gluteal muscle strength as well as reduced and fairly controlled deep core stabilizer muscle activation. Patient now presents with mostly resolved nerve irritability bilaterally with reports of only intermittent onset of nerve pain down the legs. These impairments and her current symptoms are associated with SI joint dysfunction and instability. Current symptoms currently present at progress reevaluation with mild severity and irritability and are primarily mechanical in nature. Skilled physical therapy designed to address these impairments will be instrumental in achieving the stated functional goals, including her ability to perform forward bending and lifting without pain. Whew. My recommendation. First line, 45-year-old female with continued low back complaint. Current presentation, colon, enter, bullet. Range of motion, improved hip mobility, moderate to mild, bullet. Strength, continued weakness, posterior hips, core, bullet. Stability, reduced activation at core, bullet. Radiculopathy, from constant to now intermittent down lower extremity. From there, they could add details of those bullets if they had standardized scores, which I recommend, or you could add additional bullets for those score improvements as well, or other daily activities. Ending it, symptoms and disability from moderate to mild severity since initial eval. Has achieved goals A, B, C. Goals X, Y, Z are progressing. Recommend continued PT. So the second example, again, lots of big words. Piriformis, iliopsoas, quadriceps, deep core, stabilization, activation. But there wasn't one functional score in there. There wasn't one daily activity in there. There wasn't anything really substantial. It was all a bunch of physio filibuster, okay? It was a lot of wasted time. So my recommendation is let's not do the physio filibusters. I hope that helps. Tables, bullets, get the information out there that is needed. The rest of the stuff, don't worry about it. If you have questions, let me know. Hope that helps you out. We'll talk to you later. Thanks. Bye.